You go to bed the same way you have for 40 years. Flat on your back, maybe a pillow under your knees, lights off by 10. It feels like the safest position there is. Spine straight, nothing twisted, nothing compressed. But here's what almost nobody tells you. For a growing number of people over 60, that exact position is quietly working against one of the most important systems in the body every single night for 7 or 8 hours at a stretch. Cardiologists are now flagging it directly. Sleep researchers have been measuring its effects in the lab for over a decade. And the position in question isn't some rare sleeping habit. It's the single most common one in America. Tonight, when you lie down, your body is going to do one of two things. It's either going to spend the night clearing waste from your brain and keeping your blood pressure stable, or it's going to spend the night doing the opposite. And the difference comes down to something as simple as which way you're facing. Let's start with why this has been missed for so long. Stroke prevention advice has focused almost entirely on daytime factors: blood pressure readings taken at the doctor's office, cholesterol panels, diet, exercise, medication compliance. All of that matters. None of it is wrong, but it treats the 8 hours you spend asleep as a blank space, a pause button, a time when nothing risky is happening because you're not moving, not eating, not stressed about anything. Sleep researchers have spent the last 15 years proving that assumption wrong. A 2013 study published in the journal Science, led by neuroscientist Micah Nedergaard's lab at the University of Rochester, showed that the brain has its own dedicated waste clearance system, now called the glymphatic system, that activates almost exclusively during sleep, flushing out metabolic byproducts, including a protein called beta amyloid, that's strongly linked to vascular damage and cognitive decline when it builds up. A follow-up study out of Stony Brook University, published in the Journal of Neuroscience in 2015, used real-time MRI imaging in animal models to test whether body position changed how well this clearance system worked. It did, dramatically. The lateral position, sleeping on your side, cleared waste substantially more efficiently than either lying flat on your back or on your stomach. Stroke itself remains one of the leading causes of long-term disability in adults over 60 in the United States, and the American Stroke Association has been explicit that a meaningful share of that risk sits in categories most people never think to screen for. Sleep-related breathing disorders chief among them. That's one piece. The second piece is cardiovascular, not neurological, and it's arguably the more urgent one for people over 60. How your sleep position interacts with breathing, oxygen levels, and blood pressure overnight. And why, for a specific and very common group of people, back sleeping turns a manageable condition into a dangerous one. Here's the mechanism, and it starts with something you may already know you have without ever being told the full picture: sleep apnea. Obstructive sleep apnea happens when the soft tissue at the back of the throat relaxes during sleep and partially or fully blocks the airway, causing repeated pauses in breathing, sometimes hundreds of times a night. What most people don't know is that apnea severity isn't fixed. It changes dramatically depending on which way you're lying. This is called positional obstructive sleep apnea, and clinical sleep studies estimate it affects somewhere between 50 and 60% of everyone diagnosed with OSA. When you lie flat on your back, gravity pulls the tongue and the soft palate backward, directly into the airway, narrowing the passage your breath has to travel through. Roll onto your side, and that same tissue falls away from the airway instead of into it. In sleep lab recordings, the same person can show a mild, barely there apnea pattern while side sleeping, and a severe, repeatedly obstructing pattern the moment they roll onto their back. Same person, same night, same throat anatomy. Completely different risk profile, purely because of position. Now connect that to what happens in the bloodstream during an apnea event. Each time breathing stops, oxygen levels in the blood drop, a state called hypoxia. The body responds to falling oxygen with a stress reaction. The sympathetic nervous system fires, adrenaline and cortisol spike, and blood pressure surges upward, sometimes by 20, 30, even 40 points systolic, in the space of a single obstructed breath. This isn't a one-time event. It's repeating, potentially hundreds of times over 8 hours, night after night, year after year. Over time, this repeated nocturnal blood pressure surging damages the lining of blood vessels, the endothelium, makes arterial walls stiffer, and creates the exact conditions that precede a stroke: unstable pressure, vascular inflammation, and an increased tendency for the blood to clot. A landmark study published in the New England Journal of Medicine, following over 1,000 adults for more than a decade, found that people with moderate to severe untreated sleep apnea had roughly 3 times the risk of stroke compared to those without it. And the risk climbed further in older age groups, where blood vessels have less elasticity to begin with and less capacity to absorb repeated pressure spikes without lasting damage. Sleep lab data on positional severity backs this up with hard numbers. In patients with confirmed positional apnea, the apnea-hypopnea index, the standard measure of how many breathing disruptions happen per hour, is commonly double or even triple in the supine position compared to side sleeping in the exact same patient on the exact same night. And there's a timing detail that makes it worse for anyone who assumes a few hours of back sleeping doesn't count. Apnea events cluster more heavily during REM sleep, which is concentrated in the second half of the night, meaning the hours right before waking, when most people have long since rolled onto their back out of habit, are often the hours doing the most cardiovascular damage. Here's the part that makes this especially dangerous for people over 60 specifically, and especially for women. The classic image of sleep apnea, a loud, chronic snorer, usually pictured as an overweight middle-aged man, leaves out a huge portion of the people who actually have it. After menopause, hormonal shifts change the tone and stability of the upper airway muscles, and women's apnea often looks nothing like the stereotype. It's quieter. It doesn't always come with dramatic snoring. It shows up instead as unrefreshing sleep despite 8 hours in bed, morning headaches, waking up 2 or 3 times a night to use the bathroom, brain fog that gets blamed on normal aging, and daytime fatigue that no amount of coffee seems to fix. Because it doesn't match the textbook picture, it goes undiagnosed for years, sometimes for decades. Research on sleep apnea diagnosis gaps estimates that up to 80% of moderate to severe cases in older adults are never formally diagnosed, which means the nightly blood pressure surging is happening completely invisibly with no name attached to it, while daytime numbers at the doctor's office look perfectly normal. This is the same invisibility problem we've talked about before with nighttime blood pressure patterns that never show up on a daytime reading. Except here, the hidden mechanism isn't just a number, it's a repeating physical event that's actively straining blood vessels while you sleep, and the body gives almost no obvious daytime warning that it's happening. The only real clue is often reported by someone else, a spouse or partner who notices pauses in breathing, gasping, or restlessness, which means people who live alone are at particular risk of this going unnoticed indefinitely. Sleep medicine researchers have also flagged a diagnostic gap tied specifically to age. Primary care visits for adults over 60 tend to focus on the conditions already on the chart: blood pressure, cholesterol, blood sugar, and fatigue or brain fog gets absorbed into "that's just what getting older feels like," rather than triggering a referral for a sleep evaluation. That gap is exactly where this risk hides for years at a time. There's a third layer to this, and it's the one entirely within your control. The habits that make positional apnea worse compound with the position problem itself, turning a moderate risk into a severe one. Alcohol in the evening is the biggest one. Alcohol relaxes the same throat muscles that are already prone to collapsing during sleep, and research shows it can increase the number and length of apnea events by 30 to 50% on nights it's consumed, even in people with otherwise mild apnea. Sedative sleep aids carry a related but different risk. They don't just relax the airway, they blunt the brain's arousal response, meaning the body is slower to wake itself up and gasp for air when oxygen drops, extending the length of each low oxygen event. Weight distribution matters too, particularly weight carried around the neck and abdomen, which adds physical pressure on the airway, specifically in the back sleeping position. This is part of why positional apnea often develops or worsens gradually with age-related weight redistribution, even in people who were never diagnosed with sleep issues earlier in life. Nasal congestion is the quieter fourth factor. Seasonal allergies, chronic sinus inflammation, or simple age-related changes in nasal tissue force more mouth breathing at night, which further destabilizes the airway and makes the tongue more likely to fall backward in the supine position. And there's a feedback loop worth naming directly. Untreated reflux, which is already more common after 60, tends to flare specifically when lying flat, and the resulting throat irritation can make airway muscles even more prone to collapse. So the back sleeping position and the reflux problem end up reinforcing each other, each one making the other worse across the same night. None of these habits cause the underlying anatomy, but every one of them makes a bad night measurably worse, and all four are more common, not less, after 60. So here's the protocol. 4 concrete changes in order of how much control you have over them, starting tonight. Step 1. Change your default sleep position to your side, not your back. This alone addresses both mechanisms we've covered. It reduces airway obstruction for positional apnea, and it's the position associated with the most efficient glymphatic waste clearance in the brain studies we mentioned. If you're a lifelong back sleeper, your body will roll back over out of habit. So use a physical barrier. A body pillow positioned behind your back works well, or the low-tech tennis ball in a pocket sewn onto the back of a t-shirt trick that sleep clinics have used for decades, uncomfortable enough to interrupt the roll onto your back without waking you fully. There are also commercial positional trainer devices, small wearable sensors that vibrate gently when you roll supine, if the low-tech version doesn't stick after a couple of weeks. Give this 2 full weeks before judging whether it's working. Most people wake themselves partially the first several nights while retraining a decades-old habit, and that's expected, not a sign of failure. Step 2. Elevate the head of your bed, not just your head. A stack of pillows under your head alone can actually worsen airway angle by flexing the neck forward. What you want instead is elevation of the entire upper body, using either a wedge pillow under the mattress or risers under the bed frame's head end, raising it 30 to 45 degrees relative to the rest of the bed. This reduces the gravitational pull on throat tissue and has been shown in sleep studies to lower the frequency of apnea events, and it has the added benefit of reducing nighttime acid reflux, which is extremely common after 60 and independently disrupts sleep quality. Adjustable bed bases accomplish the same thing electronically if a wedge doesn't fit your mattress setup. The target is a smooth incline through the torso, not a sharp bend at the neck. Step 3. Get screened, especially if you recognize any of the atypical signs we covered. Morning headaches, unrefreshing sleep, nocturia, a partner reporting pauses in breathing, or daytime fatigue that doesn't match your activity level. A home sleep apnea test is far more accessible than people assume. Many can be ordered through a primary care doctor without an overnight clinic stay, using a small, at-home monitor worn for 1 or 2 nights. This isn't a step to put off for someday. Untreated moderate to severe apnea is the mechanism doing the damage, and position changes alone, while genuinely helpful, may not fully resolve moderate or severe cases without additional treatment such as a CPAP device or an oral appliance fitted by a sleep specialist. If a home test comes back positive, ask specifically whether your apnea is positional or non-positional. That single result determines whether side sleeping alone will meaningfully help or whether it needs to be paired with a device from the start. Step 4. Adjust the evening habits that compound the risk. That means no alcohol within 3 hours of bedtime, being cautious with over-the-counter or prescription sedative sleep aids if apnea hasn't been ruled out, and managing weight where it's a factor, not as a cosmetic goal, but specifically because reducing neck and abdominal weight measurably reduces airway collapse during sleep. Treating nasal congestion, whether that's an allergy medication, a saline rinse, or addressing chronic sinus issues with your doctor, removes one more obstacle standing between you and steady breathing through the night. None of these 4 steps requires new equipment you can't get within a week, and most people notice a difference in morning grogginess within the first 10 to 14 nights of consistent side sleeping alone. Now, 2 mistakes that undo this progress even when people think they're doing everything right. The first is treating "I don't snore loudly" as proof there's no apnea. As we covered, this is especially misleading for women and for anyone whose apnea presents quietly. Absence of loud snoring is not the same as absence of risk. The second is choosing the wrong kind of elevation. Piling 2 or 3 regular pillows under just the head instead of elevating the whole upper body. This is an easy trap because it feels like the same idea, but flexing the neck forward while the torso stays flat can actually narrow the airway further, working directly against the goal. If you're going to elevate the frame or use a proper wedge, not a stack of bed pillows. A third quiet mistake: stopping the changes the moment sleep feels a little better, before a follow-up sleep test or a doctor's conversation confirms whether the underlying apnea is fully addressed. Feeling more rested is a good sign, but it isn't the same as having the airway mechanics and nocturnal blood pressure surges actually resolved. Here's the reframe worth sitting with. We've spent decades treating stroke prevention as something that happens entirely in daylight, at the doctor's office, on the treadmill, on the dinner plate. But your body doesn't stop working on stroke risk when you close your eyes. For roughly a third of your life, an entirely separate set of mechanisms is running: airway mechanics, oxygen delivery, blood pressure regulation, waste clearance from the brain itself. And every one of them is shaped night after night by something as small and as free as which direction you're facing when you fall asleep. You don't need a new prescription to start on this tonight. You need a pillow behind your back and the willingness to notice for the first time that flat on your back was never actually the neutral, safe default it felt like. If this opened your eyes to something your doctor hasn't mentioned, hit the like button and subscribe. We cover what doesn't fit in a 10-minute appointment. Visit healthhustleacademy.com. We've put together the exact tools and supplement resources we talk about in these videos. All links are in the description. Take care of your body. Nobody else is going to do it for you.